Hello everyone. I'm going to be going to do a lecture on renal and urinary function, and I actually should say dysfunction also. And this is a little bit different. We usually do pathophysiology in the classroom, but we're going to try this in an effort to catch up with our syllabi. So we're going to start with UTIs, urinary tract infection, fairly common. Most people know what they are. Inflammation of the urinary epithelium following colonization by some pathogen within the urinary tract. Bacteria is almost a very common cause of UTI. Retrograde, all that means is backward. The bacteria come from the outside and it's moving back into the urethra, and it then can go into the bladder, and it can crawl up the tree to the kidney. So classification of UTIs, a couple different ones, located within the urinary system or an association with complication of factors. And an important thing to remember here is that sepsis, it can result particularly in the elderly and the immunocompromised with just a simple UTI. And we all know it's very hard to pull anybody out of sepsis. So here we have our uncomplicated UTIs, meaning they're isolated. Initial infection, or it occurs within 1 year of a prior UTI infection. So if we continue to get them, they are no longer going to be called uncomplicated, but complicated. Recurring UTIs have been treated successfully with the recurrence of an infection within 5 to 10 days after resolution of an original episode. So we've treated them, but within 5 to 10 days after stopping the treatment, they've got another infection. So those are recurring. Persistent UTI is a persistent infection despite at least 3 days of treatment with antimicrobial agents. So maybe it's resistant. Bacteria is persistent, causing by a resurgence of the same microorganism after incomplete suppression from the administration of antibiotics. Reinfections can be caused by different bacteria species. It doesn't have to be only from one bacteria. Most common pathogens you're going to hear me say over and over, it basically is usually it's E. coli, because we know the stool can house E. coli and the areas are fairly close. You can also get it from staph, Serratia, Klebsiella, and Proteus. Virulence of urinary pathogens is whether they have mucus or why are they strong, is because we have mucus secreting glands in the female. The length of the urethra and secretions from reproductive glands is the male is much longer, so we get them more because ours is so much shorter. And then the urine pH and constituents of urine. So going back to the common pathogens, 90% of UTIs are caused by E. coli. That's usually the culprit. Urine pH is usually 6, no higher than 7. So we know it's a little on the acidic side. If it gets to 9, usually the organism will be Proteus. Bacteria that contain the enzyme urease, it will cause an elevation in urine pH. And the enzyme will split the enzyme into ammonia and carbon dioxide. The ammonia combines with water-forming ammonium ions plus hydroxyl ions, raising the pH, but usually the organism is Proteus. So what that tells you is that Proteus survives in more of a basic type of an environment. So again, urine pH is usually 6, on the acidic side, no higher than 7. If it gets to 9, usually the organism is going to be Proteus and not E. coli. So here's some risk factors of UTI. Short urethra, again, that predisposes the female. The males have a much longer one. Close proximity of the urethra to the rectum, again, more for the female. Decreased estrogen in aging women promotes atrophy of the urethra opening towards the rectum. And so there you have it. Another thing after menopause, which predisposes the women to urosepsis. Sexual intercourse, frequent use of feminine hygiene sprays, tampons, sanitary napkins, anything that's going to cause chemicals in that area to possibly get it out of that acidic 6 that we need that area to have, or the pH of 6. Pregnancy puts a lot of pressure on that area also. and we've got a lack of estrogen sometimes in pregnancy. Whoops. Hormonal influences within the vaginal flora, wet bathing suits, frequent submersion into baths or hot tubs. And what is this last one here? I can't pull it up. It's indwelling catheter. Well, there you go. Significant source of infection in patients who are hospitalized. And that's why we don't like to put catheters in anyone anymore. It's because, we're outside that entire area. It's a very sterile system from the kidneys to the urethra, to the bladder. Kidneys, ureters, bladder, all sterile system. Then the urethra is sterile, and the very tip of the urethra going out into an area that's not sterile. So let's look at cystitis, or urinary tract infections. Bladder infections is cystitis, inflammation of the bladder. The symptoms: frequency, dysuria, urgency, nocturia, all of these. Urgency to void, like you feel like you've got a void and only a little bit comes out. Dysuria is difficult urine. Nocturia is voiding at night, in the middle of the night. It can be cloudy, foul smelling. It should be clear. In fact, the more yellow your urine is, shame on you. That means you need to drink water. Urine should basically be clear. Hematuria is blood in the urine. Fever and chills, sometimes fatigue, lower abdomen and or suprapubic pain. You may not have all of these. You may just have frequency, dysuria, and urgency, and just not feeling well, or cloudy urine. But the longer it goes without antibiotics, the more you're going to see all of this stuff in there. Treatment, we're going to give them antibiotics. That's antimicrobial therapy. Increased fluid intake. We're trying to flush all this stuff out. Drink. Avoidance of bladder irritants and urinary analgesics. And urinary analgesics, the big one that you can buy over the counter now, you didn't used to, is pyridium. That's pyridium. That will actually almost anesthetize the bladder so that you don't feel the spasms or the difficult urination. Okay, the first one I'm going to talk about, other than cystitis, we're going to go on to pyelonephritis. So this one's a little bit more severe. Acute infection of the renal pelvis and interstitium. So what is that? The renal pelvis is the center of the kidney. Urine collects here and is funneled into the ureter. It is shaped like a funnel and collects urine from thousands of nephrons located in the middle of the kidney, which enables it to collect urine from all parts of the kidney. So basically, the renal pelvis is a filter that strains the kidney. The interstitium is the area in the kidney sparing the glomeruli. The glomeruli filters blood components through 3 layers. So you get an infection, basically it sounds like it's the center of the kidney. E. coli, here we go again. Cause of most acute cases. Repeat infections is going to cause scarring that changes blood flow to the kidney, the glomeruli, and the tubular structure. Filtration, reabsorption, and secretion can be impaired if we've got scar tissue, and there's a decrease in renal function. Acute pyelonephritis is an active bacterial infection that can cause interstitial inflammation, tubular cell necrosis, abscess formation in the capsule of the kidney, cortex or medulla, temporarily altered renal function, but this rarely progresses to renal failure. Untreated, though, may cause urosepsis, which can lead to septic shock and death. So acute pyelonephritis, what does it look like? Sudden inflammation caused by bacteria that primarily affects the interstitial area. I already said that. More common in females. Incidence increases with age. We talked about the estrogen level atrophying the area. So it's closer to the rectal area, and that's why E. coli is probably most likely the culprit. The etiology, what causes it? It's bacterial infection of the kidneys. Infecting bacteria usually are normal, intestinal, and fecal flora that grow readily in the urine. One of the most common renal diseases, it can affect one or both kidneys. Prognosis is good with treatment, and it's more common in females because of the shorter urethra. And here it is. Most common organisms, and you can read them here, but it's going to be E. coli. That's why it's bolded there for you. Pathophysiology. The infection spreads from the bladder to the ureters and then to the kidneys, as in the vesicoureteral reflux. Bacteria may create colonies of infection within 24 to 48 hours. Infection also will be created by instrumentation, meaning if we're going in for procedures, catheterization, that's what we do. That's why we stress so crazy to you that it has to be a sterile procedure. Cystoscopy is when they go up with an instrument and actually view the bladder. And then any urologic surgery. You suppose most of these surgeries and procedures would have prophylactic antibiotics on board? You betcha. Hematogenic infection, well, we've got a blood infection going on. A septicemia or endocarditis of lymphatic infection. Anything to do with the lymph, because we know it goes everywhere. It develops from an inability to empty the bladder. Patients with neurogenic bladder, it's not going to empty right. Urinary stasis, meaning the urine is going to stay in the bladder. Urinary obstruction due to tumors. That's what's going on with my dad right now, with all of the lymphatic masses in his abdomen. One of the largest ones is sitting on his bladder, and he still has a catheter. He's had it for quite some time, but he cannot empty the bladder. And we know if we have stasis of urine in that bladder that he is going to be prone to an infection. And he's prone to an infection more than the average bear now because of he's going to be on chemotherapy. So again, urinary obstruction due to tumors, strictures, or BPH, or benign prostatic hyperplasia. Clinical manifestations, meaning what does it look like? Similar to the bladder infection, cystitis, urinary urgency, frequency, burning during urination, difficulty urinating at night, and sometimes the hematuria, it says usually microscopic, meaning you're not going to be able to see the blood in the urine, but when they examine it under a microscope, we can see it. Cloudy urine that has an ammonia-like or fishy odor. Any cloudy urine is never, ever good for anything. Temperature 102 or higher, shaking, chills. Now we've got a kidney infection. This is big stuff. Nausea and vomiting. Flank pain is like in your lower back area. They call that the flank area. Anorexia, obviously you don't feel well. Symptoms develop rapidly over a few days, and they may disappear without treatment, but they'll return with a worse infection. Okay, this will be, we'll conclude here. Let me see. Actually, let's do one more. Just complications would be septic shock, chronic pyelonephritis, so we would go from acute to chronic if it's not taken care of, and then chronic renal insufficiency, which is not good for anybody. All right, that ends the videotape 1 for our renal dysfunction.